Hi.
Hi, Sandy. Do you want to go ahead and see if your share screen works?
I sure can.
Okay, wonderful.
Seeing that? Yeah.
Yeah, and you can put it in presentation mode.
Yep, getting there.
And we have our student who is going to go ahead and introduce you, and we'll get right into it.
All right.
Good morning, everyone. My name is Marina Bucci, and I have the pleasure of serving as the moderator for our next session. I'm a second-year student within the DPT program at the University of Central Florida, and my clinical areas of interest are orthopedic and sports. I have a few housekeeping items to mention. Please visit our presenting sponsor, Delsis, all day in the virtual exhibit hall. Their exhibit hall is really awesome, honestly. You can find that link in the chat all day. Our new lunch hour is also hosted by Delsis. We're also hosting a raffle at 12:40 p.m. And so please remember to join us at our networking social at 4 p.m. And if you're on social media, we would love it if you would join us and tweet and post along with the hashtag IEPRS21. Finally, throughout the next lecture, feel free to ask your questions in the Q&A. We'll try to address them as they come in. Before I introduce our next speaker, just wanted to thank all of our sponsors. Our next session has been sponsored by New Life Rehab. New Life Rehab is situated on 43 rolling acres in Mount Dora, Florida, only 35 minutes from Orlando. As one of the largest residential post-acute rehabilitation facilities in the Southeast, with the staff possessing over 200 years of experience, New Life Rehab provides comprehensive programs for neurologic rehabilitation to support and promote the development of the quality of life for their patients. All of us at UCF would like to thank New Life Rehab for their support. It is now my honor to introduce our next speaker, Dr. Sandra Billinger. As a professor at the University of Kansas Medical Center, Dr. Billinger leads the Research in Exercise and Cardiovascular Health Laboratory in the Neurovascular Division of the KUMC Alzheimer's Disease Center. Dr. Billinger is an internationally renowned speaker on exercise testing and interventions in older adults with chronic conditions such as stroke and Alzheimer's disease. She has over 70 publications in peer-reviewed journals and has served as the chair of the Stroke Rehabilitation and Recovery Committee for the American Heart Association Stroke Council. Dr. Billinger was also awarded the American Heart Association Stroke Counselor Lecture Award in 2016, and she received the Staten Norton Teaching Award and the KU Chancellor's Distinguished Teaching Award in 2016 as well. She is also the president of the KU Medical Center's Women in Medical Medicine and Science. We're honored to have Dr. Billinger with us. Dr. Billinger, the mic is yours.
Thank you. And thank you for that very nice introduction. I appreciate it. So today I'm going to talk about something that we're really excited about. It's been a new development in our lab, looking at dynamic cerebrovascular response during acute exercise following stroke. No, why are we not advanced? There we go. So I do need to disclose that I have current funding from the NIH. It covers a majority of my salary, so I need to disclose that. And I am a majority stakeholder in a pending patent, although that doesn't influence anything in this talk. So you can answer there in the chat, and I've really just wondered, like, how many people have really thought about how the cerebrovascular system responds to exercise? You know, Dr. Grooms talked about, muscle, and we talk about, neuromotor and the brain, but I often wonder how many people, think about the cerebrovascular system. Yeah, so nice, very good. And then we have a second question, that comes up. So what does the audience think? Do you think that blood flow increases linearly with heart rate during various intensities of exercise? I'll be curious to see what people think. Yes and no. All right. Well, you guys are just going to have to wait to find out the answer. All right, here we go. Off my screen. I am having some PowerPoint issues here. It is not wanting to go. There we go. All right, so the objectives for today is just, I really want to, I changed them a little bit from what's on the internet, and I really want people to understand how exercise interventions may support overall brain health. I think this is so important with the aging population, and then thinking about secondary stroke and prevention. And then, characterizing the acute response and having the attendees understand, how this may translate to stroke recovery, thinking about how this knowledge may affect our therapeutic strategies in stroke rehabilitation. And this is really driven by, not just interest in exercise, but there's been some advancements in thinking about, high intensity interval exercise for stroke rehabilitation. So first, I'm just going to start off with an overview on brain health. And, I was really excited when this publication came out from the American Heart Association. It really started looking at how can we define optimal brain health in adults. And the American Heart Association put forward Life Simple 7. And what it's looking at is, whether or not people smoke. And really, this is just the traditional cardiovascular risk factors, monitoring blood pressure, cholesterol, your BMI, blood glucose, physical inactivity, all of those things that they measure, what they were saying, this is something that we need to think about for brain health. And I've been saying this for a while now, and you'll see some of this data, but I really do believe, I always put out to the students, hashtag heart health for brain health. All the things that we do for our heart are good for our brain. And so, across our lifespan, if we think about these things, we have neurodevelopment, we have environmental exposures and behaviors. What do we choose to do as we're growing up, going to college, in our early adult years, our social environment, and all of this can either positively or negatively affect our brain health over the lifespan. But then AJ, also has this where our vascular risk factors, and again, those things that are in Life Simple 7 can also affect not just our heart here as we think about development of atrial fibrillation, cardiomyopathy, heart failure, but also these can go back and forth. And if you have heart failure, myopathies, atrial fibrillation, valvular disease where blood's not, leaving the heart and getting delivered to other organs, especially the brain, you can get small vessel disease, large arteries atherosclerosis, so in the carotids or the aorta, and then that can affect structural and functional injury. And again, I think this, if we think about this, it ties into, what Dr. Grooms was talking about. And if we think about even, our athletes, but as we get older, if we have small vessel disease and we have older adult athletes or individuals who want to start exercising as they're older, this, these lifestyle factors can affect brain health over the lifetime. And so recently this publication actually just came out probably about 2 weeks ago, but they actually on the optimal brain health, they talked more about how these modifiable risk factors affect the life course and specifically moving it towards brain health, again, just to get that message out, heart health for brain health. So I wanted to share this study that I work very closely with the Alzheimer's Disease Center here in Kansas City. And I'm very fortunate because the neurologist, Dr. Jeff Burns, is one of the co-directors, and he is very interested in lifestyle interventions. And I often hear him also talking about heart health for brain health. So, it's just really exciting here in Kansas City about how we're looking at all this, bridging heart health for brain health. But again, the study was picked up after we published in PLOS One in 2015, and looking at the New York Times did this piece on the right dose of exercise. And what this was a trial, we called it TEAM, and it was a trial of exercise, aging, and memory. And they had 100 people with normal cognition. They were sedentary or underactive, and they went through stretching and toning, which was the control. And then we manipulated the dosage. And again, it was the intensity started at 40 to 45%, and we bumped them up in a progressive dose response. But we always kept the groups as one group was 75 minutes, the other was the recommended public health dose, and then the other was 225 minutes. And we did it in a community setting. Again, they could go to the YMCA of their choice. But what we saw was the stretching and toning had no change. And then we see this dose response in better cognition measures with exercise. But I was really interested in, the cognition when we published this, the R squared wasn't real great for attention and some of the memory. So I thought, well, what if we tested the cardiorespiratory fitness hypothesis and really looked at, those individuals that gave us a good effort on the first test, gave us a good effort on their post-test. So we know that physiologically, we can attribute some of this change to the intervention, and we saw the R squared go up. So again, I really feel like when you look at exercise testing and fitness, again, if you can get really good tests and we think about the intervention, do those people who really benefit from the intervention, how does that affect brain health? And again, we saw this much stronger correlation to the memory scores. So just summarizing this part of it, I think, I'm hearing in the literature and more that fitness change is really important. Not just good fitness, but if you're doing interventions, that change in fitness is really good for brain health, cognition, Alzheimer's disease. And we think about this as now as other related dementias. We're learning more that dementia is sort of that umbrella, and Alzheimer's, vascular dementia, frontotemporal dementia, all those fit underneath that. And we really need to find ways in which we can improve brain health. There's my Heart Health for Brain Health hashtag. All right, so then moving on into stroke. So my K award when I first started my faculty position was really looking at, peripheral vascular health and whether or not we can advance or improve their vascular health through an exercise intervention in people earlier after stroke. Most of the work had been done, in chronic stroke, but we really wanted to enroll, within 15 days up to 3 months. So in that early period, and I really felt like we were doing some really aggressive intervention in this early stage, and this was, 10 years ago. And so this was just a pilot that I had done with 10 people. And again, I acknowledge the small sample size, but it was an 8-week intervention. We wanted to look at this recumbent stepper, and then really look at really a rigorous exercise parameters for these 10. Like we really wanted to make sure that we didn't go over, we wanted to make sure we stayed within these blood pressure ranges. The rate of perceived exertion, we wanted to be between 12 and 16. Again, people are on beta blockers after stroke. And so we wanted to get an idea of how they were rating their RPE. And then we really tried to strictly adhere to these exercise intensities, and we reported on, the adherence to these heart rates. And then with the outcome measures today, I'm just going to focus on pre-post just because of time. I also won't talk about the functional outcome or any of the cardiorespiratory health measures. We published this work in the Journal of Neurologic Physical Therapy in 2012. I'm happy to share the article, although it should be freely available. But just talking about flow-mediated dilation, and the reason is as we move to the brain, I just want people to have an understanding of kind of just this vascular health if you're not familiar with it. So we do flow-mediated dilation. We've updated this. This is an old device I was trying to create or build to hold that probe steady, so that, you want to hold that probe steady so you don't have any movement of the person who's doing the scanning. But we've got a much sleeker device now. And then you put a cuff right below the antecubital space of the elbow, about 2 inches below. We learned through trial and error this cuff is too big. We actually have one half the size now, and it's much better placement. But what happens is when we do flow-mediated dilation, again, for those that may not be familiar with this, we get resting blood flow. And then we go ahead and inflate that cuff to about 200 millimeters of mercury. If their blood pressure runs a little bit higher, we might go to 220. So you have this period of ischemia that, we have them hold that for 5 minutes. And so everything downstream of the cuff and the lower forearm is vasodilating to get blood there. Well, when you release that cuff, you have this big increase in blood flow, which we call reactive hyperemia. And that increase in blood flow pulls on the inner wall or the endothelium and kind of tugs at that. And the vessel says, whoa, wait a minute, we have all this blood flow coming in. We have this cascade of cellular signaling, that creates that shear, that pull on the wall. And so we get a release of nitric oxide and a lot of other vasoactive metabolites. And so here's the vessel, and again, here's the baseline, and you can see that when the vessel has that shear, this is a young healthy person, you get this nice floamated dilation response. And again, the reason I'm showing this data is as we transition to the brain, I wanted you to have this mental picture of, as we exercise, we get that shear when our heart starts beating, cardiac output increases. And again, we get that shear and we get vascular dilation. And so again, thinking about that in the brain. And the reason this is important is that, most people have between 8 and 12. I have seen some really lean runners who, had an FMD of about 15, but typically we see between 8 and 12. And then the literature suggests that any FMD measure that's below 5 is actually very indicative of poor vascular health or cardiovascular disease. So I don't have time to go into these unilateral differences that we've seen, but I've typically noticed this and studied this in my dissertation for my Ph.D. and then also in my early career. But we see that there's these vascular changes on the stroke affected side that are very different. We've seen it in chronic stroke, in this study, in the subacute phase, and then my K award also focused on the acute phase and early hospitalization and follow-up a week later. And we still see that there's differences between the stroke affected and non-stroke affected side. So after this 8-week intervention, both vessels in the brachial artery increased by 18 to 19%. We got over, for some people, that 5% value, but I was hoping we'd be able to get them to the, with the intervention, to similar to the non-affected. But again, we had the similar improvement, which tells me that people after stroke can have vascular improvement, which is great for reducing atherosclerosis. And then not a primary outcome measure, but it made total sense in retrospect, is that we had this not only statistically significant difference, but also a clinically meaningful difference. And so blood pressure reduction clinically, whether medication or exercise, a reduction in 10 millimeters of mercury is clinically significant. And we met that criteria. I didn't expect to see much of a change in diastolic. It dropped, but not a lot. And I just want to say that we also looked at medications, and people were not changing medications during the time of the study, just because we wanted to make sure that there wasn't somebody got a vasodilator or we're on a beta blocker or something that helped that. So as I was presenting this, and again, this was rather novel, Rich Macko, who's a mentor and a great colleague and friend of mine, said, Sandy, I love what you're doing. Have you ever thought about, brain health and cerebral vascular measures? I really think that's the way of the future. And so I started thinking about that. Really, I've done from carotid arteries down, and I'm looking at people with stroke. Why haven't I thought about the brain? So this is where we are moving now. So as a quick question, seeing if people are paying attention, which of the following lifestyle cardiovascular risk factors are important for brain health? I'll let them. So when we think about lifestyle that are important for brain health, number 2, if you answered 2, that would be the most correct answer. While exercise glucose is important when we think about those lifestyle factors, exercise is not one of them, it's resting. That may have been a little bit of a tricky question. My colleagues who do metabolism would say exercise glucose is important, but when we think about the Life Simple 7, it would be, number 2 would be the most correct. All right. It really just does not like after that poll. There we go. So in summary, we know that vascular health is important for brain health. When we look at our exercise and interventions for the FIT principle, and again, this is frequency and time, intensity, time, and type. We're going to talk a little bit about intensity later. We talked about frequency. And again, when we think about that dosing, we had different minutes across. And again, we found that more minutes and more time exercising is actually better for improving cognition and fitness. It does help, exercise does help reduce vascular dysfunction, and we can look at that as floamated dilation. Other people will look at large artery stiffness. Pulse wave velocity is another measure I didn't talk about, but that is commonly used. blood pressure is just a real important one, and it's something that's easily measured. It's something that, you know, all of us as healthcare professionals, athletic trainers, physical therapists, we should do this all the time. You know, it's really important. It improves endothelial signaling. And really, when we think about these, this is both fitness and reducing vascular dysfunction is so important for overall secondary stroke prevention. And if we can get individuals to improve cognition and fitness, it just really, cardiorespiratory fitness is so strongly tied to mortality. And so again, if we can reduce early mortality, that's always a positive for our patients. So moving forward, you know, when I started thinking about these cerebrovascular health measures, I started thinking, well, how can we look at this as something, you know, in the realm of what I do, which again, I'm trying to build off my K award and thinking about vascular health. What can we do to think about a biomarker for brain health? And can we help, you know, with what we do in ultrasound, can we help put more pieces together for this puzzle? So when we think about overall blood flow, you know, right now, all of us, if we're sitting and sedentary, we have a certain amount of blood flow, our cardiac output, and we're listening, and so we have brain activity. But really, when we think about exercise, we get this increase in metabolic demand, blood pressure changes, our arterial blood gas changes, and also cardiac output. And so this is a measure of arterial spin labeling. I'm not an expert in this type of imaging, but certainly this is commonly used, and the brighter areas in the reds are where more blood flow is going over time. And, you know, again, as Dr. Grooms was talking about the MRI work that he does, and, you know, there's some people that, you know, in our older adults that can't go in the scanner. We've had people with different types of maybe cochlear implants, hearing aids, pacemakers, some stents that can't go in the scanner. And some people are claustrophobic. And so again, we were trying to think of other ways in which we could leverage the technology in which our lab provided to also think about things that we could do. So again, we used transcranial Doppler ultrasound. We can measure blood flow in the middle cerebral artery. And so what we can get is beat to beat, not just blood pressure and heart rate, but we can also get velocity from the transcranial Doppler ultrasound. So much like blood pressure, we can get systolic velocity, we can get diastolic velocity, and then we can get the mean velocity, which is the area under the curve from the start of the wave of the velocity of the blood flow velocity, and we can look at that value. Now each technique, excuse me, each technique has its benefits. And so if you think about what we had up here, you have really good spatial resolution. Again, you can look exactly at these spots and measure them where there's increase in blood flow. You can even look at hippocampal blood flow. And so we can't do that with transcranial Doppler ultrasound. But what we like to do is with exercise. And so in order to do that, we need something that we can tolerate movement. So again, we don't have the spatial resolution, but we can get the temporal resolution. So we just published, and just to kind of give some background, we just published this work in the Journal of Applied Physiology. And on the y-axis here, we have middle cerebral artery velocity. So again, it's that mean value. And then we have aging over time. And so we worked with Dr. Jill Barnes at the University of Wisconsin over in Madison, and then Dr. Patrice Brassard at the University of Laval in Canada. And we pooled all of our resting data from our 3 sites, and we have the largest data set, over 500 people, showing this trajectory between looking at both age and sex differences. So the dashed line is females, and the solid line is males. And what we found is that young women typically have higher blood velocity. And there's a paper that just came out actually that did similar work in arterial spin labeling in the brain. And so they have actual flow, found very similar findings that females have higher blood flow at the younger ages. But then when we reach postmenopausal, we have sharper declines, but we still have a little bit higher blood flow. And again, our sample size is a little bit weak in the older as we get above 80. but we see that we start to catch our male counterparts, and honestly, this is similar to what we see in the cardiovascular literature for heart attack and stroke. Past menopause, we really start to catch up with that risk with our male colleagues. We do need to acknowledge that there's a little bit of a gap here in middle age. I've been really happy there's some calls out to study middle age. And I think for cardiovascular risk factors, thinking about Life Simple 7 and all those things that we need to do for heart health and brain health, we really need to understand this earlier. So this is the setup in our lab. We use a recumbent stepper. We do this because we work with people with stroke, and the bike typical cycle is a little bit harder for people if they have hemiparesis. But on the finger, we get beat to beat blood pressure. That comes over in the FinaPress. Here we have transcranial Doppler ultrasound. We use robotic probes for this, so we can do this during exercise real cleanly. Our EKG, we use the R wave as the trigger, so that actually we time align everything to that R spike, because once the electrical activity of the heart fires, we know that we're going to get a blood flow velocity and a blood pressure. We also measure CO2 output. The brain is very sensitive to CO2, so we look at that as well with the capnograph. So when we think about modeling, so I really got this idea of, a lot of the literature looks at data at rest, and then it looks at it during exercise. But there's this change piece about what's happening with exercise. And there's a lot of literature in muscle blood flow and VO2 kinetics, where they model this, this response. And so that you have a really quick up phase, and then phase 2 is where it starts to plateau and then steady state out. And so I was really curious, like, can we do this in the brain? How much does blood flow even go up in the brain with exercise, and do we know? And I couldn't find anything in there. So I was very excited to really come up and develop this this technology, or this kind of apply, I should say, not develop, but apply a novel methodology and a modeling to brain blood flow and cerebrovascular health. So again, we use the equipment in the picture that I showed earlier. Again, we want everybody resting for 20 minutes to have stabilization of blood pressure, heart rate, and blood velocity. We have them rest for about 20 minutes, and then we use the ACSM guidelines for moderate intensity exercise. We have them sit for 90 seconds. We have them rest. We get our recording. And then it's just a continuous, we go from rest to exercise, and we do this for 6 minutes. Typically what we do in our young healthies is we do 3 transitions. So we'll have them do this rest to exercise. We allow everything to come back down to baseline. We repeat that again, allow everything to come back down to baseline, and then do it again. And then we average the 3 together to have nice data points to do our modeling. This doesn't work for older adults with stroke. We get 2 bouts. By the 3rd, we just found that they were just too tired and the data was too messy. So this is what this looks like. And we published this in 2017 in the Journal of Applied Physiology. On the y-axis is MCAV, and we have time across the x-axis. So here you see we have rest, and then we have exercise onset at the dashed line. The time delay is how much time goes to when you get an exponential rise in the response, or in this case, it's middle cerebral artery velocity, before it starts to rise. And again, we're using a well-established equation that's been used in the literature and published for VO2 kinetics and muscle blood flow. Tau is the time that it takes, or the time constant that it takes to reach 63% of the curve. Amplitude is the highest point, and that dot, I think the arrow may have moved a little bit, but it's the highest point as it reaches steady state. And then we get cerebrovascular response, or what we call CVR. And this is the average of the data in this period from 3 minutes to 4.5 minutes. And I'll talk in a minute why we do that and why that's important. So here on the top is a young, active, healthy adult. And this is just one. This is one person. It's not an average. In this paper, it was a methods paper, and we were just showing the response. And then we have sedentary older adults. So you can see there's a little more noise, and that exponential rise is not as clear, but we can model it. It's just blunted in older adults. And then this is a person with middle cerebral artery velocity. I'm sorry, this isn't a person, again, we're measuring the MCAV, but they had a middle cerebral artery stroke. And so you can see that here's rest. We started the exercise. There's a long delay. It goes up, but then it just kind of stays steady. And this is why we get the CVR, because this model failed. It will not model because there's no exponential rise, but we can get the data at 3 to 4.5 minutes. So just some unpublished data, and I'd appreciate not maybe taking pictures and tweeting this out if you're on Twitter. We're working on getting this published, but if you look at this, we can model the heart rate. So again, what we did before, we're going back and we're taking all of our data. So if you look at this, this is that 90 seconds of rest. You can see the heart rate responds very differently, very quick with exercise onset, and rises with low, moderate, and a moderate high intensity. Although I'm going to guess that maybe we were exercising them above their anaerobic threshold because of the heart rate drift here. You can see blood pressure. There's just a little bit of a delay. We get a little Valsalva with the start of exercise, but again, you can see low, moderate, and this moderate high intensity exercise. And then here's our transcranial Doppler ultrasound. And again, when we think about autoregulation and the stability of the brain, there's just a little more time, although it looks a little quicker in the higher group. But here again, we have low, moderate, and this moderate high. The reason I also say we may have been exercising them a little harder, when you start to hyperventilate and PaCO2 goes down, we start to get this drop in MCAV. So when we look at this with stroke, for some of you who may not go back into the late 90s or may not have been looking at stroke. Stroke was really contraindicated when I first got in the field, and I could not figure out why, because they were cardiovascular patients, but we know that's not true. And I was taught that the brain was not plastic, and we know that that is very not true. But exercise for brain health was very much understudied in stroke. And with everybody looking at high intensity locomotor training or thinking about interval training post-stroke, I got really interested when there was this paper that came out in 2015 and another one in 2020 that, the cerebral vascular response with these on-off cycles and these up-down, there's rapid fluctuations in blood pressure. And so how does the brain handle that? And should we be doing it in stroke? And so again, one of these, in this study, it's not HIT or any type of interval, but we wanted to characterize this in people at 3 and 6 months post-stroke. And I really thought that these individuals would get better over time, so that they would come in at 3 months, and then at 6 months, their MCAV response during exercise would get better, and that physical activity would be related to their overall response. And so I'm going to just kind of skip over this for time. But what we found is there was no significant differences for outcomes at 3 and 6 months. Now, we did lose some people at 6 months, but we did some linear mixed modeling to account for dropout, but we didn't find any differences over time. And we didn't find any differences between gender or race. But what we did find, which I thought was really interesting, we had some people who modeled and some didn't. And, that's always frustrating when you want everybody to model in this exponential way so you can characterize it. But we had 12 out of our 26 people, and then 22 we had some data that was messy that we had to throw out, or didn't. They had atrial fibrillation, and that kind of is very hard to model when you have a lot of changes in their heart rate. But we had 12 people who modeled and 10 that didn't. And we looked at everything like what could be different with them. And what we found is that their fitness level, if they were active at the time of their visit and when they came in, they had a much better response than those who didn't exercise. And we looked at treatment, TPA, mechanical device, thrombectomy. We looked at blood pressure medications. The only other thing that was different was whether or not they were on a statin. And we know statins affect vascular health. We just got this published in the Journal of the American Heart Association. So the dark filled in circles, this is their non-stroke affected side, or in the journal, we had to change this language to ipsilesional and contralesional. But this is the contralesional MCAV. So you can see this really nice response. And on the strokes affected side, it's blunted, but the people who exercised actually looked really good. And then we look at the non-responders, and they go up really early, and then they just, never really increase. But you can see this kind of waveform here. And again, when we think about that, is the MCA following pressure identically, which is not what it should do. So again, for these people, should they do HIIT, where you're challenging their system with that constant on-off cycle? And we don't have that answer yet, but it definitely intrigues me. So during this time, we had an individual who actually had 2 strokes. And this was, like a science, it was a science miracle, where you could say, oh my gosh, we could really look at the effect of stroke. And it's unfortunate for the individual, but we're looking at how's this response after they had the stroke. And in this case, we actually got to see these changes after this individual's second stroke. So this is Carolyn Kaufman. She's an MD, Ph.D. student. She's about to defend her dissertation in a month and going back to medical school. But again, we see this 20.6% difference between the two, the right and the left. And so in this case, the right is the non-affected, and the open circles are the affected. And so during the exercise response, we see a 50% difference. Now, this is a comparison to baseline. So over time, they've lost a little bit of their MCAV response. And again, it's a little bit decreased. But look at the difference after the second stroke. So you can see that here, this individual was cycling, and here they were really inactive. But again, there was not a lot of differences in the size of the stroke, where the stroke was, their NIH stroke scale score. Not much was different. The treatment was the same. The size was the same. It was in the same near location. And so again, there may be something to physical activity. So for those of us who are working with our patients, physical activity may be really important for overall brain health. We saw a really big drop in his cognition too during that second visit. So future directions in stroke, we really want to target for improved brain health, whether that's secondary stroke prevention, vascular dementia. I think we need to really understand the short-term effects of different exercise intensities. We need to look at the continuum of low, moderate, and high, and certainly continuous versus interval exercise. And then thinking about the FIT principle. And then, a lot of people are interested in brain and neuroplasticity, but how does exercise mediate that? Or when we think about cerebrovascular health. So I'd like to thank everyone for the invitation. This is a great conference with amazing speakers, and I was honored to be invited. And so I thank Dr. David Fagutka and Matt Stock, my lab team, both past and current. Without them, I wouldn't have these data. My collaborators at the Alzheimer's Disease Center, the stroke team, and the participants. So I'm happy to take any questions at this time.
All right, so we just have one question. Is just asking about how increasing the metabolic demand differs for acute versus chronic stroke patients. Like, how would you go about doing that?
Yeah, so is the question more about like if they have hemiparesis, or just like it really in that acute, like days after stroke? Is that?
Yeah, mainly just
Yeah,
in the days after stroke versus a couple of weeks after.
Yeah, we started in the acute phase like 3 days after stroke, and it it is a little bit harder because of fatigue and recovery. So one of the things you have to be able to have people do is step at a steady state cadence in that, and as they're starting to recover and learn their function, and with the the neuro response, I would assume the metabolic demand would be a lot higher because they're still trying to get that movement back. But I bet our data, would be harder to model that. I have a feeling that, in people with a large MCA stroke early, I think we'd get a much more blunted response than when they've been stabilized, they've been in the community moving around, or at least at home in the chronic stage.
Perfect, yeah. Thank you. And I guess just to go off of that, so do you kind of model your interventions based on where they're at in their recovery stage then? Or just the intensity of the interventions? Yeah,
I think the intensity of exercise, if you're looking at prescription for overall health, so I helped write the overall guidelines for exercise after stroke, and it's really modeled after older adults. It follows that, and there's some question of, well, would it really be different? And I think if you talk about overall cardiovascular health, it's not necessarily a different messaging, because again, for blood pressure, glucose, cholesterol, all those numbers are the same. So, you know, would it be any different? But I think there's unique differences about people with stroke with hemiparesis. I think they have different challenges. I think they might benefit, you know, potentially from higher intensity activity to improve that vascular health because they've had a stroke, and we want to reduce that chance of early morbidity. You know, more and more evidence, and even when we wrote those guidelines, more evidence is showing that people with stroke have a lot of cognitive deficits. And so I think we have to understand what's the best exercise prescription to benefit their brain health. And can we get at that? I think those are the next important questions we have to think about.
Okay, cool. And then we just have one last question. It says, have you also measured brain blood flow to the posterior circulation? If so, are there similar decreases with the PCA that you've seen with MCA?
Yeah, so you know, there's a lot of work that's been done in the PCA, and it's a really great question, and thank you for that. We have not done the PCA. The reason is that the MCA delivers the majority of the blood flow to the brain, and we can get a better sense. Like when we look at the carotid arteries, you know, that's almost a straight, you know, to the internal into the MCA and then into the brain. And what we've seen in the literature with healthy people, we've seen that, you know, the MCA and the PCA act almost similarly in the response. Like it, you know, it'll go up and it goes down. There's really nothing different there. So we've stayed with that. However, for stroke, it's probably important to look at the PCA, especially if they have a posterior circulation stroke. So that's a good question and something we haven't done. You know, if we do the PCA, we have to bring them back for multiple visits, and we just really wanted to reduce burden in this initial one. But it is something we should look at, and thank you for that question.
Well, great. Well, thank you so much for your time, Dr. Billinger.
Very welcome.
Really appreciate it. And for everyone who's still watching, if you would like to stick around later, I'll be able to answer some questions during the 4 p.m. session.